Welcome back, guys. This time we shall be talking about heart sounds, part 2. I'll be focusing on second heart sound first, which is characterized by aortic and pulmonic valve closure. The time lag between the aortic and pulmonic valve closure both do not close on the same time. The gap between the two is approximately 30 milliseconds. This is technically called as physiological splitting of the second heart sound. The physiological splitting of second heart sound is best heard in the phase of inspiration. So whenever you see a physician asking the patient to hold his breath, and he's putting his stethoscopes at the S point, then he's trying to listen for the splitting of the S2. In the paper they have asked regarding the position of the S point. The S point would be the left side of the chest, the third intercostal space. Parasternal line. I've just used a short form here. PSL would mean parasternal line. So I repeat my statement. Every time you see a physician putting his stethoscope on the chest of the patient at the ears point and asking the patient to take a deep breath and hold it there, he's trying to check for the splitting of the second heart sound. And this physiological splitting of the second heart sound has a time lag of 30 milliseconds. Now if this gap will be less than 30 milliseconds, we call it narrow split. And if the gap is more than 30 milliseconds, we call it a wide split second heart sound. So I'll be giving some clinical conditions to you. I will not start by saying whether it is narrow or wide. I'll just describe the condition and you will be able to evaluate whether it is a narrow or a wide split second heart sound. In the first sketch that I'm making before you, I'm showing valvular aortic stenosis. So if you look at this particular sketch, you see the surface area of the aortic valve is approximately 2.5 square centimeter. And I have made it really small. So if this opening is smaller, the left ventricle will eject this blood into the aorta of the patient. There's obviously going to be a turbulence, there's obviously going to be a murmur in the patient. But at the moment, we are just focusing on the fact that in all patients with valvular aortic stenosis, you can see that our heart is genetically programmed to kick out 80 ml of blood. I want you to compare this patient with yourself, because you can see the opening is smaller. The exit of 80 ml blood, if you just imagine this person sitting on a chair next to you, the basic point is because the exit of 80 ml blood from the smaller opening will take relatively extra time. Therefore, the aortic valve of the patient cannot close on time and the aortic valve will show relatively a delayed closure. In case you missed it, I'll say that again. I want you to compare this patient by yourself. The opening is smaller. If the blood has to go out of a smaller opening, it will take extra time. And extra time will translate into the aortic valve will close relatively later. If the aortic valve of the patient will close later, I'm going to put these two lines, the A2 and the P2, on a two-dimensional scale. And then I'm going to say that because aortic valve will close later, I'm going to shift it slightly to right to say that the gap will become relatively lesser between the two lines since they're coming closer to each other. So in patients who are having valvular aortic stenosis, the delayed closure will result in development of a narrow split second heart sound. The best management for a calcified stenosed aortic valve is aortic valve replacement. But let me say, poor patient in India did not get aortic valve replacement surgery done. Then this is a progressive condition and this gap will become even more narrowed. And if this gap will become narrowed, then I think you would agree that exit will take still more extra time. In these circumstances, what's going to happen in the patient is that the aortic valve will close still more later, and the gap will become progressively reduced, and there can be a possibility one day that the aortic and pulmonic valves might start closing at the same time. The aortic valve is closing later, still more later is superimposing, and there's a possibility that both are closing at the same time. Then we're gonna call it a single S2. And there is also possibility in these patients that the aortic valve closure might occur after the pulmonic valve closure. You can see the overshooting happening here. It's coming closer, superimposing, overshooting. The overshooting is called as P2A2. This would be referred to as a reverse splitting of the second heart sound of the patient. So the sequence that I want you to remember is that in all patients of valvular aortic stenosis, pending a treatment, the patient will be having first a narrow split second heart sound, does not take treatment, gets converted into single, and then gets converted into a reverse split second heart sound. Max to max in some MCQs, instead of writing the word reverse split, he might write the word paradoxical splitting of the second heart sound of the patient. So this is the sequence that you should be aware of. And in the exam, you see, you won't have time to, draw these lines and understand it on a two-dimensional scale. They don't even give you a paper pencil. So it's just an orientation that I want you to have right now, because in the exam, you operate on a reflex. So the message is that exit will take a relatively extra time. Aortic valve closes later. That is why you are having a delayed A2 and a subsequent series of events that I have explained to you. The best management for these patients is AVR, that is aortic valve replacement. Well, just let's look at why do you have aortic stenosis anyway presenting to you. In the exam, if they give you valvular aortic stenosis for an infantile presentation, then the most common cause of valvular aortic stenosis in infantile age group is bicuspid aortic valve. However, if he begins by saying a child, then it is rheumatic heart disease, and in rheumatic heart disease, all of you are aware that mitral valve is the most common one to be involved, but the second most common valve involved is the aortic valve. So child with rheumatic heart disease would be having aortic stenosis. Aortic stenosis is not seen in young people, so it's not going to be seen in you at, let me say, 25 years of age, or me at, let me say, 42 years of age. In an adult patient, if they say, you are unlikely to have this aortic stenosis presenting at your or my age group, most of the time it's going to present in geriatric age group, that is after 65 years of age. And the reason for this geriatric population, geriatric presentation, is senile calcification of the valve. So one, you have to understand that this disease has a bimodal age of distribution. It is either seen in pediatric age group or is seen in geriatric age group. And why do these patients of valvular aortic stenosis come to us? That is because of SAD, SAD. This is a triad which has been asked a couple of times. S would stand for syncope on exertion. This syncope on exertion is explained by low cardiac output in these patients. Since you can see there's a valvular narrowing, so the cardiac output of the patient is very limited. So if he's trying to climb stairs, like let me say with a backpack on his back or any kind of load or a rucksack on his back, whatever, then low cardiac output can cause ischemia of the brain and syncope, patient can pass out. A would stand for angina in these patients. The reason for angina in these patients is, and I'll just swap the slide for it, that in a lot of these patients, because there is an obstruction in the heart, there would be a compensatory LVH, a left ventricular hypertrophy. And you know that whenever there's a left ventricular hypertrophy in a patient, the oxygen demand of the heart will increase. This mismatch between demand and supply, because demand is more, you see more muscle, more demand, supply is going to be normal. I'm not saying supply is lesser, mind my words there. I never said supply is lesser. I said demand is more, supply is normal. So there's a mismatch between more demand and a normal supply, that is subendocardial ischemia, which in English we call as angina. This angina is because of mismatch between the demand, which is increased, and the supply, which is normal. The third manifestation in these patients is going to be developmental difficulty in breathing, which is anyway presentation of any cardiac case, and here the increased left ventricular filling pressures will explain the pulmonary edema component. The dyspnea is diastolic malfunction. SAD is a triad which has been asked in the paper for valvular aortic stenosis. Now let us see what are the examination findings of these patients. Apart from the heart sound aspect that I mentioned before you, we will also evaluate the pulse in this patient. The character of pulse is best evaluated in the carotid artery. This is the tracing of the pulse that I'm gonna show before you for all of us. The pulse tends to peak in the middle of systole, then the pressure tends to ease off and you have a dicrotic notch, and then you have is a fall. In fact, they have simply represented this dicrotic notch in an image-based question, and they have simply asked the dicrotic notch is present right after the answer is second heart sound, as you can see. The peak of the pressure is generated in the middle of systole. This peak of the pressure that is generated in the middle of the systole is a feature in you and me. In valvular aortic stenosis, because there's an outlet obstruction, a fixed valvular obstruction, it takes time for the pressure to rise, and the peak of the pulse is delayed. And you can also see that in this particular patient, I have shown a pulse tracing with a relatively smaller dicrotic notch. One of the special features of this pulse is that this is a slow rising pulse. Apart from the slow rise in the pulse, you can also notice that the amplitude of this pulse is also relatively lesser. You can also see that in this pulse tracing, the dicrotic notch of the patient is very, very small, to the level that in some cases, the dicrotic notch of the patient might practically be absent. So the basic message is that whenever you wanna read about this pulse slow rise with a decreased amplitude and a dicrotic notch which is almost absent to practically being very small or being absent, then the terms that you have to remember for the slow rising pulse is known as pulsus turdus. I'm just writing the Latin terminology corresponding to the English words. The word is pulsus turdus. At parvus, the word is to highlight the fact that there is a decreased amplitude. And for the absent dicrotic notch, the word called is anacrotic pulse. In fact, this has been a national board question that in which pulse the dicrotic notch will disappear. Then the answer would be valvular aortic stenosis, where the pulse is referred to as an anacrotic pulse. This is the first finding that I want you to remember for patients of valvular aortic stenosis, pulsus turdus et parvus / anacrotic pulse. Then these patients will also be having a double apical impulse. The double apical impulse of these patients is explained by the fact that in these patients, the heart is relatively bigger, so the apex beat in these patients can be evaluated in the fifth intercostal space as well as in the sixth intercostal space. So fifth and sixth intercostal space is where you are able to evaluate the apical impulse of the patient. These patients will also be having a heaving apex beat. The word heaving apex beat implies the fact that the impulse will be so forceful that it will lift up your finger. Then in these patients, when you listen to the second heart sound, S2, in the second heart sound of these patients, you will be able to notice that the patient is having a narrow split second heart sound. As I explained to you, this is because the opening is smaller, blood will take more time to go out of the heart, so aortic valve will close later. Though in some MCQs, he might write the word single S2 or he might write the word paradoxical S2, paradoxical split second heart sound, to imply the severity of the disease as it increases. In these patients, not only would you be having a left ventricular hypertrophy, but a left atrial hypertrophy also. I'll just represent that on the previous slide. As you can see, these patients will also be having a compensatory left atrial hypertrophy. The reason for left atrial hypertrophy is simply by the fact that the responsibility of sending blood out of the heart is not only the function of the left ventricle, but also the left atrium. So because the left atrium of this patient will be generating relatively more force, therefore in these two, or this is because in the second heart sound of these patients, you will be able to notice that the patient is having a narrow split second heart sound. As I explained to you, this is because the opening is smaller, blood will take more time to go out of the heart, so aortic valve will close later. Though in some MCQs, he might write the word single S2 or he might write the word paradoxical S2, paradoxical split second heart sound, to imply the severity of the disease as it increases. In these patients, not only would you be having a left ventricular hypertrophy, but a left atrial hypertrophy also. I'll just represent that on the previous slide. As you can see, these patients will also be having a compensatory left atrial hypertrophy. The reason for left atrial hypertrophy is simply by the fact that the responsibility of sending blood out of the heart is not only the function of the left ventricle but also the left atria. So because the left atria of this patient will be generating relatively more force, therefore in these patients the left atrial hypertrophy will generate atrial kick. Why I'm writing atrial kick is the atria of the patient is generating more force than yours and mine. So left atrial hypertrophy is responsible for generation of fourth heart sound of this patient. And since you could see the turbulence while the blood was going out of the heart, when you will be auscultating this patient, you will be able to hear a murmur. The speciality of this murmur will be that this murmur will be having an increase and decrease of the spike of the murmur. I can say the intensity of the murmur will not be constant. The intensity will first rise and then will decrease. This is discussed in the murmur section also and is called as ejection systolic murmur. Ejection systolic murmur is also called as crescendo or decrescendo murmur, as is written in Davidson, the British book. But most books do not use the word crescendo, decrescendo, but they tend to use the word ejection systolic murmur, where the intensity will first rise and then the intensity will tend to go down. So the sequence to be remembered by you is simply the fact that these patients will be having a narrow split second heart sound, an anacrotic pulse, a fourth heart sound, and an ejection systolic murmur. The best test to confirm the diagnosis of this condition will be echocardiography. Once you have identified this condition on a transthoracic echo, since most of the patients are older patients, older than 65 years of age, it is also a good idea to simultaneously scan them for presence of atherosclerotic changes in the coronary arteries. So in these patients, we also not only do a transthoracic echo, but we might even be requiring coronary angiography in these patients, because I want to evaluate that the angina component is simply because of presence of LVH, or is it due to coexistent atherosclerosis or triple vessel disease. So I will also be doing a coronary angiography in the patient, and in most of the patients we are able to identify coexistent atherosclerotic lesions. Considering the age of the patient, a lot of these patients might be having a coexistent triple vessel disease, for which they might be requiring a coronary artery bypass grafting. So they ask you, what is the treatment for this chap? The treatment of choice for symptomatic patient or severe aortic stenosis. Mind my words there, symptomatic patient, not asymptomatic. If he tries to be smart and introduces the word asymptomatic patient, then in those circumstances, for the asymptomatic patient, we do not operate. You see, the point is, asymptomatic people, it's a dicey situation, and most of the time we would like the patient to be symptomatic and then operate. But for a symptomatic severe aortic stenosis, if he says what is the best treatment, then it is AVR, that is aortic valve replacement, which is nowadays done percutaneously. And along with aortic valve replacement, if required, coronary artery bypass grafting would be also done in these patients. Do remember the fact that if in the MCQ he mentions a pediatric aortic stenosis, then there is no need of answering a AVR or CABG. Obviously, for pediatric aortic stenosis, the treatment should be given as balloon valvotomy. The main message is that you should be able to identify the heart sound in these patients with respect to the information that I have mentioned clinically plus the heart sound aspect. A lot of time in MCQs of valvular aortic stenosis, you might actually say a word that I would like to add now, and that is based on the turbulence. You can see that in these patients, there is a lot of turbulence of blood going out of the heart of the patient, which is responsible for a murmur. So another finding that I can add to the current slide, so that you can remember the features of these patients, and would be an additional examination finding of this person would be that after the murmur, I can add the word carotid thrill. Whenever you read this word carotid thrill, it is so accurate that it straight away tells you that the question is on valvular aortic stenosis. So most examiners will avoid writing this in the question in the theory part. At the same time, I also want you to pay attention to the fact that in some MCQs, he might write the word dancing carotid. If the examiner is going to use the word dancing carotid, then dancing carotids is a feature that is encountered in patients of valvular aortic regurgitation, whereas carotid thrill is a feature of valvular aortic stenosis. So though I said examiners might avoid writing this terminology, they might deliberately introduce the wrong term dancing carotids, which is not a feature of this particular condition. In some questions, however, they might actually try to trouble you by mentioning what do you mean by the word severe aortic stenosis. Then severe aortic stenosis is characterized by narrowing of the aortic valve orifice. Transthoracic echo, you can actually see the size of the aortic valve orifice. Because the opening is smaller, the ejection velocity will also increase. So definition of severe aortic stenosis, I mean, when do we say patient is having severe aortic stenosis? Then severe AS would be less than 1 square centimeter of the valve surface area. Or in some questions, he might not write the word orifice of the valve, but might actually mention regarding transvalvular gradient. What I mean by transvalvular gradient is the pressure difference between the left ventricle and the aorta of the patient. If the transvalvular gradient is given to be more than 40 millimeters of mercury, we take it to be severe aortic stenosis. And in these patients, because the opening is smaller, the ejection velocity of the blood going out of the heart is also increased. If the ejection velocity is more than 4 meters per second, we are going to call it a severe variety of aortic stenosis. Normal ejection velocity for you and me is going to be approximately 1 meter per second, but if the ejection velocity is to the tune of 4 meters per second, we call it severe aortic stenosis. A new term that has been introduced recently in MCQs has been super severe aortic stenosis. Now when I say super severe, then in those circumstances, I want you to remember that the transvalvular gradient, that is LV minus aorta pressure, should be more than 55 millimeters of mercury. Or for that matter of fact, for transvalvular gradient, he might write the word ejection velocity. These are like kind of parameters which tell you that straight away that intervention is required for the patient, because you see with these kind of values, patient is symptomatic and obviously threat to life with respect to physical activity causing angina and then possibly MI also. So super severe is more than 55, 5.5 straightforward data. The severe variety is going to be answered by you as 40 and 4 millimeter. 4 meter per second, 40 millimeter transvalvular gradient and ejection velocity more than 4, and super severe is 55 and more than 5.5. So those are like the terms that you need to remember for the severity of the disease in the patient. And just revise this data once and you'll be able to crack questions with respect to valvular aortic stenosis, which is characterized by presence of a narrow split second heart sound followed by a single, followed by a paroxysmal split, which is the important information here. Now once you get a hang of this, let's look at another perspective. This time again, I will not mention whether the person is having a narrow split or a wide split second heart sound. I'll simply draw the condition before you, and then we will evaluate whether there will be a narrow or a wide split second heart sound. So just be patient while I just make it before you. This can be taken as the representation of the aorta and the pulmonary artery. This is the pulmonary artery bifurcation. In the sketch, what I've done is that I have shown here is an anatomical abnormality, that is ductus arteriosus, which is patent. You see, ductus arteriosus normally closes after birth. In this particular case, however, I have shown patentio ductus arteriosus. You can see that the oxygenated blood present in the aorta will race obviously into the descending aorta, but some of this blood will be racing by the patent ductus arteriosus directly into the lungs of the patient. This is an example of a left to right sided shunt. You can see this is left ventricle, this is right patent ductus arteriosus. You can see that the oxygenated blood present in the aorta will race obviously into the descending aorta, but some of this blood will be racing by the patent ductus arteriosus directly into the lungs of the patient. This is an example of a left to right sided shunt. You can see this is left ventricle, this is right ventricle. If they ask you that for a case of a patent ductus arteriosus, which ventricle will fail, then the ventricle that's going to fail in this particular case is not going to be the right one, because you can see very clearly blood is not going in the right ventricle. The blood is bypassing the right ventricle, straight away racing to the lungs of the patient, and all the blood that comes into the lungs is going to race to the left side and is going to cause overloading of the left side of the heart. Therefore, patent ductus arteriosus is a condition which is a left to right sided shunt, but it does not cause a right ventricular failure, it causes a left ventricular failure. When it comes to left ventricular failure, I just want you to focus on the word failure. which is the blood that comes into the lungs is going to race to the left side and is going to cause overloading of the left side of the heart. Therefore, patent ductus arteriosus is a condition which is a left to right sided shunt, but it does not cause a right ventricular failure, it causes a left ventricular failure. When it comes to left ventricular failure, I just want you to focus on the word failure. Failure would mean that the heart is not having sufficient power, so exit of blood out of the heart will take relatively extra time. And because exit of blood out of the heart of the patient will take relatively extra time, the aortic valve of the patient will close relatively later. You can see the fact that because the aortic valve of the patient is not going to close on time and is going to close relatively later, I'm going to just show this on a two-dimensional scale before you, the aortic valve closure and the pulmonic valve closure. I've worked out before you that the aortic valve will close later, so the gap between the two will become relatively lesser, and therefore in cases of patent ductus arteriosus, there would also be a presence of a narrow split second heart sound. What you've learned at the moment is that narrow split second heart sound can be seen in physical obstruction of the aortic valve and is also seen in left ventricular failure. The logic in both of them is identical. No, in valvular aortic stenosis, there is a fixed obstruction, whereas here the heart is simply not having sufficient power to generate the force necessary to remove the blood out of the heart, so the aortic valve closes later, and therefore you have a delayed A2 and a narrow split second heart sound developing in a patient. Before I describe other causes of left ventricular failure, which would again result in narrow split second heart sound, let's just quickly look at what is the presentation in patent ductus arteriosus. When it comes to preterm children, they become symptomatic right at birth.